We're going to get started. Thanks very much to all of you for coming. Thanks to the various departments that have co-sponsored and helped us plan this event. The Bora Forman Lecture is something that we started about 8 years ago that intended to honor, and hopefully does honor, my grandparents who came to were born in this country of children of immigrants and really never graduated college, and have successfully seen the value of education and the value of healthcare, and the value of information in making our lives more meaningful. And so we've used this series for health policy across the spectrum. We've been fortunate enough to have Zeke Emanuel, Gail Walensky, so both White House advisors in both Republican and Democratic administrations, our own Harlan Krumholtz, and our own Vivek Murthy, the 19th Surgeon General of the United States, as speakers in the past. Nothing is more enjoyable than to invite back someone who's been a student and an alum of Yale. I first met Dr. Kate Goodrich in 2008 when I teach a health policy course to the clinical scholars, and we go around the room, and there's about 8 or 10 of them each year. And I remember going around, and what struck me about her was that unlike most of the other clinical scholars who were either in the middle of residency, particularly if they were in surgery, or just after residency, is that she had actually practiced as a hospitalist for 10 years before deciding to go back and do this fellowship. And I thought that was really remarkable in terms of both her commitment to her own career development, which is something that I think is central to a lot of us in this room, as well as the importance of quality improvement in her life and how she could educate herself and advance her own career in that direction. In 2009, we were fortunate enough because friends had become elected to the White House and so on. We were fortunate enough to go visit the White House in 2009 with the clinical scholars. And so I think I have, I hate to interrupt this now, so I think I'll do it at the end. I'll show you a picture from that visit when we went to Washington with Kate and the clinical scholars at that time. And since that time, her career has really been linear and ever committed toward clinical quality standards and in healthcare, and particularly through the federal government. She first went to work in the White House right after the clinical scholars, and then transitioned after a year and a half to the Center for Medicare and Medicaid Services, where she now is the director for the Center for Clinical Standards and Quality and the chief medical officer. She's going to talk today about those topics, and I could not be more happy and proud to have you come back and join us. Thank you.
Thank you, Howie. And I guess I can just press down or something. Oh, look at that. Okay. Hi, everybody. It's so nice to be here today, to be back in New Haven. Walked around downtown quite a bit last night, had dinner at Basta, just as good as ever. So it's really, really nice to be here. So today what I'd like to do is I'm going to tell you a little bit about my career path from before clinical scholars and after, mainly to demonstrate to you all sort of what a actually, somewhat atypical, but in some ways somewhat typical career path could look like in alternative careers in medicine, and how probably a lot of the stuff that many of you are doing now, whether you're a student, a resident, or faculty, actually is very meaningful for ultimately coming into the federal government or into a payer, those experiences actually do matter. Then what I want to do is give you sort of the high level, why is it that the healthcare system is changing? It's probably a lot of stuff you already know, but I want to give you the background for why the agency, the Centers for Medicare and Medicaid Services, is making this transition to value-based care, which I know you've probably heard a lot about. And then I'm going to give you sort of the very high level of what CMS is doing in this space. And I imagine as I talk through this that you'll be thinking to yourself, how does what I'm saying at a very high level comport with what your experiences are day to day as you practice medicine, teach, etc. And as I was just talking about with Howie, there is sometimes that disconnect between what payers are trying to do and talk about and what you're actually experiencing. And so I look forward to your questions about that. So I started off at George Washington University Hospital. I came there for residency. I had all kinds of designs to be an infectious disease doctor when I came there. But they started the hospitalist program when I was a third-year resident, and I loved being in the hospital. To this day, I just think hospitals are fascinating places, and I love being in them. So I ditched going into fellowship and then decided to become a hospitalist. So I was sort of your typical clinician educator. I was award attending, you know, I did lectures for students, that kind of thing. I started the evidence-based medicine curriculum. I had a bunch of administrative duties, and I just sort of put these on here, not to give you the impression that being on the P&T committee is a key milestone to glory in the federal government, but because these are probably committees that a lot of you either know about or you're on, you've participated in. And having these kinds of experiences, like I said, actually matters for my day-to-day work now at CMS. The reason I'm chief medical officer at the CMS is because I have that practical real world experience, not just of seeing patients, but of actually having a pretty good understanding of how health systems actually operate and work. And so having had the experience of being on the medication reconciliation committee, et cetera, actually makes a difference. It actually is an experience I can draw upon now when we are making policies for how to drive quality in hospitals, as one example. I ended up being the chair of the Institutional Review Board, which is 5 years I'll never get back, unfortunately. But I was actually utterly unqualified to be chair of the IRB at the time that I was. I was only like 35 years old, and I think they just gave it to me because I showed up to the meetings and had read the materials. I'm much more qualified for it now than I was then. But it actually did spark my interest in moving into understanding more about evidence-based medicine, research, and ultimately policy. And then, you know, I moved up to be director of inpatient medicine and then director of the division of hospital medicine. We actually started a PA and nurse practitioner program there, which now I'm very proud to say is about 15 strong and going very well. So it was a wonderful 10-year career plus 3 years of residency at GW. But really, with the milestone that actually did change my career trajectory to be where I am now was coming here to Yale. When I did the Robert Wood Johnson Clinical Scholars Program. I had sort of reached a point where I was just getting a little, I don't know, my learning curve had plateaued at that point at GW, and I really wasn't able to move any further. And I happened to be connected with somebody I'm sure lots of you know here, Nicole Lurie, a former clinical scholar. And at the time, she was a senior scientist at RAND. And she became my mentor, and she said, "You got to do the clinical scholars program, lady. I don't know what you're thinking about." And so I got lucky enough to get in, and just had a marvelous experience here and learned along the way that while I thought what I wanted to do was be a rock star hospitalist researcher, that's actually why I came, that actually policy was where it was at. Because it was 2008, as Howie said. And if you remember 2008, Barack Obama got elected, and everything out there in the healthcare world was all about health reform and how the health system needed to change, which was all new to me. I mean, I knew things were wrong in the healthcare system, but I couldn't really articulate it or understand what needed to be done. And that was just very, very exciting to me. Combined with the fact that I was homesick for Washington, believe it or not, that I was an opportunity to come back to Washington and to serve in the federal government. And how did I get there? From another clinical scholar who was there before me, named Patrick Conway, some of you may know. So I came to work with him, actually not in the White House, actually it was in the Department of Health and Human Services. There's an office there called the Assistant Secretary for Planning and Evaluation, which is kind of the research and policy think tank operation of the Secretary's office. So I did some work then. I don't know if any of you remember the stimulus bill from 2009, first big piece of legislation passed under the Obama administration. So that gave $1.1 billion for comparative effectiveness research. Now we know it as patient-centered outcomes research. Sort of seed money to help the department provide funding for actual research, for dissemination and translation. I was responsible for developing a multi-payer claims database, and I can tell you I have wasted $21 million of taxpayer money like no other trying to build that database that nobody wanted. So that was my job when I was at ASPE. Didn't quite work out, but learned a lot from it, and then ultimately was able to transition over to CMS, which is really where I had wanted to be because I really like operationalizing things, making things happen, and there's nowhere you can do that more than at a big regulatory agency like CMS or the FDA. And so have worked my way through CMS. I'm now, as Howie said, director of the Center for Clinical Standards and Quality and the chief medical officer, a role that I did take over from Patrick Conway when he became director of the Innovation Center. And through that, I've actually continued to practice medicine. I found that to be critically important for a few reasons. One is I went to med school and I want to feel like a doctor sometimes. So I really like seeing patients. I never get tired of it. So I round 1 week in a month at GW Hospital still. It also allows me to actually see the impact of our policies. And I'll give you an example. We used to have a measure in the hospital program around pneumonia vaccinations. And I was making rounds in the hospital and was talking to one of my colleagues who said, we've had this spate of people in the hospital who've developed cellulitis in their arm after getting the pneumonia vaccine. And turned out it was a bad batch of the vaccine and it was contaminated. And that's why people were getting cellulitis. We had 4 people in the span of about 2 weeks that got cellulitis. And when we went back and did a chart review of those patients, not a single one of them needed that vaccine. They were all well under the age of 65. But they were getting the vaccine because the hospital, as part of the quality assurance committee, had basically put a policy in place that everybody who comes in the hospital gets the pneumonia vaccine, no matter what, because of that measure. So that was really like the first, oh my gosh, we have power, and not always in a good way. So there's that. And also, just frankly, it gives me credibility because I interact a lot with all the physician specialty societies, all the societies you guys probably belong to. I talk with them and meet with them on a regular basis, patient and consumer organizations, et cetera. And being able to say that I still practice medicine and can be articulate about, what that means in today's healthcare world is really helpful as well. This may be a little elementary for some of you, but I always find it's helpful to talk a little bit about what CMS is, what it is that we do. This is very high level. So we provide healthcare coverage for over 140 million Americans, biggest payer in the country and perhaps in the world. I'm sure you're familiar with Medicare, Medicaid, and the health insurance marketplaces. I work mostly in Medicare, and we always like to joke that M in CMS is really Medicare. And the Medicaid people get very upset with us about that. So I work mostly in the Medicare space. Now, CMS is organized into 6 main policy centers. We have about 6,200 employees, about 1,100 of which are in one of our 10 regional offices across the country. And we have, in my center, we actually have a budget of about $2 billion, but the total budget is about $1 trillion. We actually control about 1/4 of the economy because of Medicare and Medicaid. So we're organized into 6 policy centers. The Center for Medicare, up until recently, was the biggest center. They run Part A and B as well as C and D, so they're really kind of divided in 2. So they oversee Medicare Advantage and Part D plans. The Center for Medicaid and CHIP Services, they work with the states and territories on implementation of their Medicaid programs. They're the ones who have to approve state 1115 waivers and other types of waivers. Center for Clinical Standards and Quality is the center that I lead. We oversee all of the quality measurement work in the agency, as well as almost all of value-based purchasing programs and public reporting, hospital compare, physician compare, home health compare, nursing home compare, all of those. We also oversee the QIO program, and we develop all of the health and safety standards, and we enforce those standards with our partners out in the regional offices and state survey agencies. So like when Joint Commission comes in and surveys your hospital, or the state agency comes in and surveys your hospital, they're surveying to the standards that we have set. The Center for Program Integrity primarily focuses on fraud, waste, and abuse. They also work on provider enrollment, so you guys have undoubtedly interacted with them as well. The Center for Consumer Information and Insurance Oversight, or CISIO, they run the marketplace. That is their big program. And then the Center for Medicare and Medicaid Innovation, the latter 2 actually were begun after the Affordable Care Act passed in 2010. So the Innovation Center, of course, develops and runs payment models, which I'll be talking about quite a bit. And our center actually collaborates very, very closely with them. Okay, so why is the healthcare system changing? This is not a new topic, I'm sure, for most of you, but for some of you, it may be helpful to give a little bit of a background as why things are changing in the way that they are. I was just thinking, Howie, as we were talking about sort of sometimes the disconnect between what we're trying to do and what's actually happening on the ground. One of my favorite speakers is Governor Leavitt, Michael Leavitt. He was governor of Kansas. He was Secretary of Health and Human Services in the Bush administration. And he came and spoke at our quality conference, which we have every year. I think it was last year. And if you ever get a chance to hear him talk, you should race to it. You should drive hundreds of miles to hear him speak. He's amazing. But one of the points he likes to make that really hit home to me is that the transition from volume to value that we always talk about, this transition to value-based care, is a 40 to 50-year journey. We've been talking about it. We're like year 15, maybe, in doing that. So if it feels like not a lot really has changed, even though you may feel some changes around the margins, That's because we're still trying to figure out how to get it right, and that we're really, really early in that trajectory. So this is a slide, this is one of my favorite slides. I stole it from Mark McClellan, who is with the Duke Margolis Center. He used to be CMS administrator. He was also FDA commissioner, both during the Bush administration. And this shows you, this to me explains everything as to why the healthcare system is changing. So the bottom blue line you see is Social Security, orange line is Medicare and Medicaid, and then the light blue is everything else. And as you can see, as you go along from 1974 to what's projected through 2034, is that everything else is getting completely squeezed out by healthcare dollars. And so in that spike you see, I don't know if I'm gonna see if this works. No, oh, there we go, yeah. So, you know, Social Security stays, you know, it's rising, but not as much as you would think from what you hear on the news, but it's definitely going up. This spike you see here is the stimulus bill. But everything else is everything else. I mean, it is defense, it is the VA, it is every other department, it is our federal debt, it is absolutely everything, and it is getting squeezed out by healthcare. And while over the last several years, you've probably read that there has been some reduction in spending on healthcare, it's been nowhere near what it needs to be. Some of it's undoubtedly related to the big recession, although some of it is actual reduction in spending, but it's nowhere near what it needs to be. So this is absolutely non-sustainable if we want to have, you know, a society the society that we're used to, or a better society where we actually spend on things like social programs. We spend less on social programs than almost any other developed country. And one of the reasons for that is because it's getting crowded out by spending on Medicare and Medicaid. So something has to be done. I'll show you a series of slides that you've probably seen something like them before. This shows that we obviously spend more as a percentage of GDP than any other country. However, what we're buying is not getting us better health outcomes, better quality care overall. There are some areas where we actually do really well. There's certainly a lot of innovation that happens in this country. We do very well with acute care, trauma care. We do well with cancer care in many ways, but with the burden of chronic disease and other things, we actually and you know, poor coordination of care, fragmented care, we actually don't do very well. And so we're spending a ton of money and not getting a lot for it. I just, you know, you can go on the internet and pick out like thousands of slides on frankly how much we suck. So that's really terrible. I shouldn't say it that way. I work for the federal government, but we have, you know, we have the mortality per 100,000 population is much higher. These are just the green and blue bars are just different year spans. We do worse on hospitalizations, avoidable hospitalizations. We overall do worse on readmissions to the hospital. So there's a lot of metrics that you could pull off the internet from reputable sources that would show you that we are not getting our money's worth in a lot of different realms, right? So how do we actually change this? And this is something people have been thinking about for a long time. This is not new. And there's two main ways that you could do this. I'm sure there's others as well, but these are large categories. One is you can cut prices. Congress could decide that the federal government can negotiate drug prices, can cut prices for, you know, a variety of different things, or we can change how we pay for care. And what this country has ultimately decided to do is option two, and it's testing a number of ways to do that. So this is a rubric that that was put forward actually by former colleagues of mine, Patrick Conway, Marilyn Tavenner, who was the administrator for CMS right after Don Berwick, which I got there. I overlapped with Don by about 2 weeks, and then Marilyn became administrator, and Rahul Rajkumar, who is currently at Blue Cross North Carolina. And they basically outlined a framework for how we define ways that we pay, right? And so category one is straight fee for service, no link to quality in any form or fashion, whether it's pay for reporting, pay for performance, nothing. Currently in Medicare, in the Medicare program, less than 10% of dollars are tied or have no tie at all to quality or cost. Category two is actually where most of our payments are right now. So it's still based on a fee for service system, but there is some tie to quality. And in most of our programs, actually, that tie to quality, frankly, isn't terribly strong. So as an example, in the hospital value-based purchasing program, we score hospitals on a variety of mostly outcome, patient experience, and cost measures and safety measures. And then we toggle their reimbursement when they submit a claim, what they get reimbursed, up or down by 2%. based upon their quality score. We also penalize hospitals for too many readmissions or too many harms. And that's either up or down by 2 to 3%, or actually only down. And then for harms, down by only 1%. So you can see those are not really strong financial drivers, even when you sort of tally them all up. They're not really that strong financial drivers. It is actually caused hospitals to take note, and there has been improvement, but not the large scale improvement that you would hope. And part of that really is because of the percentages are actually set in law. We actually can't really change them. And because it really is still based on a system that rewards volume at the end of the day. Category 3 is, you'll hear me say this acronym a lot, APM, which is Alternative Payment Model. So category 3 is alternative payment models that are built on the fee-for-service chassis, but actually allow for reconciliation of payments, usually after a year of sort of performance on quality. And allows, the one that's probably most familiar to you all is the ACO program. We call it the Medicare Shared Savings Program, where a service is still triggers a claim that gets submitted to CMS, and there's a reimbursement. But in this system, what we do is we set a target for how much an ACO can spend in a year based upon historical spending. And then if they spend above that target, they have to give some of that money back. I'm simplifying greatly here. And if they spend below that target, then they get to keep some of that money. So that's the ACO program. Also, we have some episode-based payment programs that are similar. And then category 4, which is, where most folks feel like we as a country are trying to head, is population-based payments, where payment is not directly triggered by the submission of a claim to a payer and is not linked to volume. So think of this as being like a global budget, where a system is a health system, for example, is given essentially a budget, and they have to work within that budget for a year. And if they spend less, they get to save some of that. But if they spend less and they do terrible on their quality measures, which might indicate they're actually stinting on care, then they get less of that money back, or they actually don't get to save dollars. And if they spend more, then they're at risk for that. So, over time, what I think we and other payers are trying to do is to shift providers and payments into categories 3 and 4. And so what you're seeing here are some goals that were laid out by Secretary Azar at our big Healthcare Payment Learning and Action Network conference last, I think it was October. The previous administration had set some very clear targets for moving percentages of payments to categories 3 and 4, alternative payment models. And so this administration also set targets, not just for Medicare, but also for Medicare Advantage, commercial payers, and Medicaid. And the Healthcare Payment Learning and Action Network, by the way, is a network that is really run by payers. So while we sort of support it through one of our contractors, it actually is run mostly by the commercial payers, and we participate. So as you can see, these are some very assertive goals that you see on the page here. So there is a goal that by 2025, that Medicare, 100% of Medicare and Medicaid, Medicare and Medicare Advantage payments would be through categories 3 and 4. That means as some part of a risk-bearing alternative payment model. That is a very assertive stretch goal. And I think, that was very intentional. The thing about stretch goals and assertive goals is that you're more likely to get farther even if you don't hit the goal if you set a stretch goal. So that was the idea behind this. And then looking at some of our data, we also set goals, and this wasn't just we setting it, it was also the other payers that are part of this network, which includes states, includes Medicaid, state agencies, set goals for Medicaid and the commercial sector as well. So what this has meant for us at CMS is it is now an agency-wide goal across the board to shift how we do business away from fee-for-service. That requires a shift in everything, not just payment. So in my center, it requires us to think very differently about how we measure quality. Because right now we're measuring quality at the setting level. It's very siloed. There's hospital measures, there's nursing home measures, there's physician measures, right? However, when you're talking about alternative payment models, you're usually thinking about paying more at the system level, as opposed to at sort of an individual setting type level. Our Center for Program Integrity, right? They root out fraud, waste, and abuse. And they do that because we know that sometimes people game the fee-for-service system. I guarantee you people are going to find ways, and already are finding ways to game the APM system. And so our Center for Program Integrity has to start thinking about, how do we think about fraud in a whole different world, right? And then we're also challenging states to be on this trajectory with us. And so our Center for Medicaid and CHIP Services colleagues have to be working with states on how to help them transition as well. So this is becoming an agency-wide effort. You will see publicly relatively soon some agency-wide goals that we are setting around cost and quality for the country as a whole that we're working on right now, which is very exciting. But it's definitely a very daunting task because, as you all know, as practicing clinicians, where the rubber meets the road, getting there is incredibly difficult, very complex, very challenging. Oh, sorry, I forgot I had this. This just shows you sort of where the big buckets are right now in terms of percent of payments. You know, already 35.8% of US healthcare payments are flowing through category 3 and 4 models, which is good. But I will also acknowledge that we and private payers too, are still learning how to implement and design these types of models. I don't think that it's been figured out the exact best way to do it for which type of population, for which type of healthcare setting, et cetera. But the point is that a lot of folks are well along that trajectory. And so this is a train that is definitely out of the station and moving, but I think there is a lot more we have to learn about how to do it well. And so what I want to do is transition a little bit to giving you a little bit more information about what this means for clinicians. And we actually use the term clinician at CMS. We transitioned from using the term physician because if you look at the about 1.4 or 1.5 million clinicians that bill Medicare Part B, which is who's affected by this, only about 800,000 are physicians. The rest are nurse practitioners, physician assistants, audiologists, occupational therapists, et cetera, and all of them are subject to the payment changes that are coming along. So, but I want to give you a little bit of background and history so you can understand sort of how we got where we are today with holding clinicians accountable for quality and cost. So in 2006, we launched the Physician Quality Reporting System. This is before my time. It started off as an upside only. So you got a bonus payment if you submitted quality measures to CMS. We didn't make it public. We didn't do anything with it. This was just to get people used to measuring quality, paying attention to quality, and submitting data out of CMS. And so this was purely pay for reporting. It had no consequences to it at all. 2011 comes along, and your favorite program and mine, Meaningful Use, started in 2011. And this is where, this was to incentivize clinicians and hospitals to invest in electronic health record systems, and that worked. 75% to 77% of clinicians now use a certified EHR, and 95 or 96% of hospitals do. A lot of people would argue that though it went a little bit too far by requiring that clinicians and hospitals tell CMS how you are meaningfully using your EHR. And so its intent was to not only spur adoption, but also ensure that people are using EHRs for population health management to communicate back and forth with other clinicians. And that's where the challenge has been. In 2014, as part of the PQRS program, it actually switched, and this is by law, from a bonus program to a penalty program. So if you did not send us measures, you got a ding, you got a 2% ding. But again, we weren't actually tying payment to how you did on those measures. That didn't happen until 2014, and this is part of the Affordable Care Act with the physician value modifier. This is the first pay for performance program for physicians. It was really focused at the time on group practices. We didn't actually measure or tie it to individual clinician reimbursement. And at that time, we were starting slow, so we only focused on outliers in terms of payment adjustments. So you had to do really well on measures, do really badly on measures to get any change to your payments. But that actually was overtaken in 2015 when the MACRA legislation passed, and 2017 was the first year of what we call the Quality Payment Program. And what MACRA was trying to do was, most importantly, repeal the sustainable growth rate. But in its place, it put forward the Merit-Based Incentive Payment System, or the MIPS program. And this really combined elements of PQRS, meaningful use, and physician value modifier, 3 disparate programs that had very different rules, very different statutory requirements, into a single program. Should be easy, right? Now you're 3, you're down to 1, no problem. But when we put our first rule forward, people kind of lost their minds because it actually is fairly complicated. I'll get to that in a second. I'm not going to go into weeds, I promise, but it'll at least give you a flavor of why this is so hard. And so the first thing I get asked when I talk about MIPS or any of these programs with doctors and other clinicians is, well, how are you measuring me? How do you know my quality of care? Well, historically, the measures that were in these programs were developed by physician specialty societies. AMA, lots of other specialty societies have been developing measures. They've been mostly based upon clinical guidelines and have been focused on what physicians and other clinicians can directly control. So process-based measures that are usually steps along a clinical guideline. But we are now really, well entrenched into the era, even though we're only 15 years out of 40 in, of paying for value and paying for outcomes. And in my 8 years at CMS, I have definitely seen a sea change in the approach to measurement, not just by us, but actually by many clinician societies. There's been a real recognition that paying for outcomes, particularly if you can do it at a group level, much harder to do at an individual clinician level. I will very much acknowledge that. Actually is what payers want. It actually is what matters more to both clinicians and to patients. And so what we've been seeing is more and more of these specialty societies, we actually don't develop clinician level measures. The specialty societies do, and we use them. Increasingly, they are getting away entirely from process-based measures, with some exceptions of where there are some really important ones around appropriate use and safety. And looking more particularly at patient-reported outcome measures. So, for example, one that my colleagues here at Yale and others have worked on is change in functional status after hip replacement or knee replacement. That's why you do hip and knee replacement, is to improve function. So we should be measuring that. And those kinds of things are what we're seeing a lot more of now. And we're also very much aware of the fact that one of the biggest challenges in measurement as a practicing clinician is the fact that you have contracts with 7 different payers, and they're all asking different things of you. They're all asking different measures, and that's just not okay. There's no way that you can respond to 42 different things that you have to improve. And so there's actually a fairly significant body of work going on right now to align measures across the public and private sector, which I will just tell you has been a very rewarding experience, but is an incredibly challenging experience. Not because we can't get to agreement, but because of the differences in the ways that the private payers actually collect data and what they're looking at and what we do at CMS. So just briefly a little bit about the quality payment program. You can either be in the fee-for-service based side, which is MIPS, or you can be in an alternative payment model. And if you're in an alternative payment model, in particular one that takes on downside risk, you actually get a 5% bonus just for being in that model. And the law did that on purpose in order to incentivize people to move from being purely in fee-for-service, MIPS, into alternative payment models. And our goal at the agency is to move people out of MIPS and into alternative payment models. Some people think that maybe we have made MIPS so painful that people will flee to alternative payment models. And there's probably some truth to that. But that actually was not our specific intent. I'm not going to get any deeper than this. I'm not even going to say a lot about this, but this slide should tell you why it's so complicated. The law requires that we assess clinicians under MIPS on 4 things. If I were queen of the world and wrote the statute, I would focus probably just on these 2, quality and cost. Those are the ones that really matter. But the law says we have to assess you on quality improvement activities that you're undertaking in your practice, and on what we rebranded meaningful use. Now we call it promoting interoperability because it is actually more focused on interoperability. But just think about it. You're in a practice, you're seeing 25 patients a day, you have to keep up with all this stuff. And so we need better systems to be able to capture this information without disrupting workflow and other things. But it is nonetheless a fairly complex program. But what I will say in its favor, that we hear over and over and over again, is that it has focused people on quality in ways that the previous programs really didn't do as well as they could have. And so to me, that is a really positive thing. It's a really positive outcome. But I think there's still a lot that could be done to simplify this. But the reality is that this is where we want people to go, right? Is into alternative payment models where you're really working within a larger healthcare system or entity, incentivizing team-based care to improve outcomes for patients, to be as efficient as possible. I point this out here, MIPS APMs and advanced APMs, because the law also said you can only get that 5% bonus and get out of MIPS if you're an advanced APM, and this is what an advanced APM is. The first two aren't hard. You have to use a certified EHR, and you got to report quality measures. I mean, they're hard, but they're like, you have to do that in MIPS too. Number 3 is really the kicker. It says that in order to be in an advanced APM, you have to either be part of the APM has to be a medical home model, or that it has to take on downside risk. So it has to have some money on the table that it could lose if it doesn't meet certain quality and cost targets. And that's the key there. The good news is, though, we now have about 100,000 clinicians who actually are in advanced alternative payment models, which is up by about 80,000 from just 2 years ago. So the trajectory is going in the right direction for sure. And I think what I'm going to do now is, well, here's some examples of some advanced APMs you may know about. Bundled payments for care improvement. These are episode-based payment models. Comprehensive primary care plus is really around targeting advanced primary care practices. Actually, the average size of these practices is 4 clinicians. And this is a multi-payer model, which is where we want to go as much as possible for everything else, because if you're a clinician, you have to respond to one model from Medicare and one model from Blue Cross and one model from Humana or whoever. The incentives may not be aligned. So this has been a really good model because all the payers are in it together in 7 different regions of the country, which makes it so much easier if you're a practicing clinician. I already talked about shared savings, and we also have a specialty model. I mean, we have 2 or 3 specialty care models. We need more of those. One of them is the oncology care model, which does qualify in one of the tracks as an advanced APM, where oncologists take on downside risk and are accountable for episodes of care around giving chemotherapy. And given that it is now about 12 after 1, I think I'm going to skip the rest. I'm happy to share these slides. We have a whole initiative around improving how we do measurement, where we're removing low-value measures, really trying to advance getting to more electronic measures using the most modern up-to-date standards like the FHIR standard, and then working with other payers to align. And then importantly, I think in order for people to be successful moving into these models, they have to have rapid cycle data feedback on their own performance, on their patients' utilization. They have to know when their patients hit the hospital. They have to know when their patients, go to another clinician. And so that's something that we are actively working on, and I think you'll be seeing more from us to be able to support clinicians moving into these models. Just quickly, future of our healthcare system. This is where we think things are going again over the next 25 to 30 years. What exactly alternative payment models will look like, I don't know. We're still experimenting. The Innovation Center was stood up to experiment. So the fact that some haven't worked out as well as others was expected. Some have worked out, or we've learned a lot from them, and the next iteration of them will be based upon those learnings. But we think that we will be focused a lot on primary care, as well as physician-focused, potentially specialty APMs, and really focusing more on population-based payment. We have got to have collaboration between CMS and commercial payers. I don't personally believe this will work unless we can do that and be totally aligned. System redesign, patient-centered, team-based coordinated care is the norm. I think most people are in agreement that those are the places we need to go. Focus on quality and outcomes. And I want to end with this because I really think this is so, so important. This is why it has been such a privilege to work at CMS for as long as I have. I think physician leadership and clinician leadership, my deputy is a nurse, and we sort of unofficially think of her as the chief nursing officer for CMS. And she was in practice for 25 years. It is critical to have clinicians being at the table, influencing and making the decisions around how these things should go in collaboration with payers and patients and consumers and so forth. But nobody knows how the healthcare system works like the people who are actually working in it. And so I very strongly believe that we will not be successful unless we meaningfully engage with clinicians. That doesn't just mean us going out and talking to you, but it means, hopefully bringing some of you into the house with us at CMS to be able to be influential in this realm, because clinicians really do have to lead the change in order for this to be successful. So I will stop there. I'm happy to take questions, and thank you for your attention.